Can you hear me?
Very well. Ladies and gentlemen, it's my honor to introduce Petya Chaveeva from Bulgaria, Sofia. She's one of the prominent figure in perinatal medicine field. Then I've asked him to share her, practice and the knowledge about the holoprosencephaly, what we can do, especially in early diagnosis of holoprosencephaly and other clinical picture. Mike is yours, Petya. Welcome.
I hope that you can hear me and I hope that you can see my slides.
I see.
And good afternoon, everyone. It's a great pleasure for me to present in this important webinar. And personally, I would like to thank Professor Jihan Sen, always up to date in what is new and how to keep our knowledge continuing even in this hard time for everyone. Today I will be presenting and I will be discussing holoprosencephaly. And this is a condition that is defined by a heterogeneous group of cerebral malformations resulting from either failure or incomplete cleavage of the forebrain, the prosencephalon. And the prevalence of this condition is found in very early first trimester prior to 11 weeks in about 1 in 250. And at about 12 weeks, the prevalence is found to be 1 in 3,000, and at birth is 1 in 10,000. There is a wide world accepted classification, and it stratifies this brain abnormality in 3 major groups. And these are allobar, semi-lobar, lobar, and midline variant. And I would just briefly try to summarize the features of those 3 brain malformations. And when we are discussing about allobar holoprosencephaly, this is a malformation of the brain that is characterized of fail of division of the cerebral hemispheres into left and right, and it appears with 1 single monoventricle, and there are no midline structures. The falx cerebri, the interhemispheric fissure, there is an absence of septum pellucidum, corpus callosum, and the 3rd ventricle. And the thalami are fused in this particular allobar holoprosencephaly. In the semi-lobar holoprosencephaly, this is another variant. There is a small interhemispheric fissure that is mainly recognized in the posterior part of the brain. There is also absent of cavum septum pellucidum, of corpus callosum, and also the 3rd one is when we are recognizing the lobar part of holoprosencephaly, when there are clearly very small and tiny lateral rudimentary ventricles, you can see, and there is interhemispheric features, and we can recognize this type of holoprosencephaly by the communication of the anterior horns in their posterior regions. Also, in this type of holoprosencephaly, the cavum septum pellucidum and the corpus callosum could be partially absent. Now, just to remind you from the embryology point of view, when there is the formation of the neural tube, and there are at 3 to 4 weeks of embryo development, 3 primary brain vesicles, and they represent the prosencephalon, the forebrain, the mesencephalon, the midbrain, and the rhobencephalon, the hindbrain. And then further splitting of the prosencephalon into telencephalon and diencephalon, from which the cerebrum, dicap, the thalamus, hypothalamus are formed. And actually, this is when it's happening that occurs this brain malformation at about 3 to 4 weeks of brain development. Now, when in the last 20 years, there is a major shift in ultrasound scanning from the second towards the first trimester, and this is mainly after the introduction of the first trimester screening for chromosomal abnormalities. And in the many units around the globe, there is a standard protocol how we need to evaluate the fetus at 11 to 13 weeks. And I will just go briefly in and summarize this protocol. And it's important to visualize the skull and the brain, and we use the transverse section of the head when we can see the skull, the midline, the choroid plexuses, then move on to examine and assess the profile with retronasal triangular, the orbits and the lips, visualizing the spine and the longitudinal section with the vertebral bodies and overlying skin, and assessing the heart in relation to visualize the four-chamber view and the V-sign. The thorax, the shape of it, and the lungs, the development, and the diaphragm. Going down, we need to visualize the stomach, bladder, and umbilicus, and also see the extremities in relation to demonstrate the feet, the hands, and the long bones, and the movement of the fetus. At this stage of the pregnancy, we are used to take the mid-sagittal view of the fetal profile, where we will be seeing the fourth ventricle and intracranial translucency, something that I'm sure that Denise lately will discuss in further details. But trying to examine the nuchal translucency, we are trying to identify a group of pregnant women with high risk of chromosomal abnormalities. We need also to see and check for other hints. And this is a recent publication from Argyros Ingilaki and the group of Professor Nicolaides, that they have examined more than 100,000 singleton pregnancies at 11 to 13 weeks. And I want to draw your attention that in the central nervous system anomalies that are accounted about 50%, those that are always detected are those of acrania and a lobar holoprosencephaly. And just because nowadays we are seeing an increased number of multiple pregnancies, either because of advanced maternal age or the use of ART procedure as a matter of conception, we need to know what is the prevalence of these defects if we are scanning a multiple pregnancy. And again, the same group has demonstrated in more than 6,100 multiple pregnancy divided by dichorionic and monochorionic twins, that the prevalence of structural defects are more likely to occur in monochorionic twins, 2.8 versus 1.3%. And now let us look how they're spreading between all the defects that are always detected, sometimes detected, and never detected. And here they have found that holoprosencephaly and the lobar form is always detected in 11 to 13 week scan, even in multiple pregnancy. And this feature is most common for the monochorionic twins. And this is something that I will not surprise you, because this is a feature of the midline defects that are more characteristic for this type of pregnancy. Now going to discuss the ultrasound finding at 11 to 13 weeks. As I have mentioned before, in the routine ultrasound examination in axial plane, we need to demonstrate the choroid plexuses that are the intrahemispheric fissure, the falx cerebri, and that there is a liquid, a good amount of it, that is surrounding the choroid plexuses. A striking finding is also the third ventricle, and what we can see in the midbrain view in this early gestation is also the aqueductus of Sylvie, that you cannot really see in the late second trimester, but is something very characteristic for the first trimester. And having Professor Asim Kuriak here in the panelist, from his extensive research of how to use 3D volumes and how to implement them, we can use the tools of our machines, IVC static and 3D, to illustrate that there is a complete separation, that there is a intrahemispheric fissure, the falx is there right and left hemisphere. Having the section of the so-called the rabbit plane from Professor Mallinger, we can assess the brain at 11 to 13 weeks, and we can see very clearly the choroid plexuses, and going down we can assess the third, the fourth ventricle at this stage of the pregnancy. And from Professor Pio and later from Waldo Sepulveda, that has described that the main feature for assessing the brain at this early stage is the butterfly sign. And having this image of the brain, we are sure that it is developed normal. Now, when we miss the butterfly sign and we are seeing a very enlarged monoventricle, and we can see the fusion of the thalami, then this is a very striking finding at 11 to 13 weeks, because this is how we can think of diagnosis of a lobar holoprosencephaly. And not only the appearance of the brain, but when we are scanning at 11 to 13 weeks, some other findings could help us, and those are the increased nuclear translucency. And when we are examining the fetus, we can also identify the in relation to trisomy 13, the polydactyly, the hyperechogenic kidneys, and the increased heart rate. We also see, in relation to the severity of the brain malformation, the accompanying facial defects. And in the video that was running, there was very clear the case with the proboscis, but I'll come to that a little bit later. Now, in relation to when we diagnose the lobar holoprosencephaly, we know that this is a detectable malformation at 11 to 13 weeks. But what about the other two variants of holoprosencephaly, the semilobar and lobar? And the semilobar holoprosencephaly could be identified at the first trimester, and it needs to have an expert neurosonography examination. But the lobar holoprosencephaly is a diagnosis that belongs to the second trimester. It is male diagnosed more than 18 weeks of gestation. There have been distinguished specific ultrasound features that could help us. And having said that, I'll go to one of the publications from the Bernal, from Professor Yves group, that has been demonstrating in the coronal plane the view that Professor Mallinger also advocated to be a crucial ultrasound view for us to assess the brain, and having that for differential diagnosis of lobar holoprosencephaly. And you can see that the arterial callosum artery is very well represented with the color Doppler, the pericallosum artery, and you cannot see in the lobar holoprosencephaly the same finding, which is also a hint to have that diagnosis. And what are the two main differential diagnoses when we are talking about lobar holoprosencephaly? And those are the septo-optic dysplasia and isolated absent cavum septum pellucidum. And when we are seeing a lobar holoprosencephaly in the second or in the third trimester, we need to be very careful how we will assess the frontal horns, because in the lobar form there is a communication in their posterior part. When we have doubts about is it truly septic-optic dysplasia or lobar holoprosencephaly, then later in pregnancy, mainly in the third trimester, an MRI could be a useful tool in relation to assess the optic nerves. And where in the septo-optic dysplasia there is an absent cavum septum pellucidum, which is also a finding in the lobar holoprosencephaly, you can see a strike relation of the anterior horns, but there is no communication in between the horns, which is not which is true for the lobar holoprosencephaly. Now, in relation to the accompanying,
would you like to discuss?
Can you hear me?
to discuss the genetic part?
Yes, briefly, I can just, if everybody can, yes, just to summarize, really, I was, my lecture has stopped I'm sorry, there was some problem in the internet maybe, but what I wanted to point is that it is very common, the association of fetal of holoprosencephaly with facial defects that are from all very well known. And what is needs to be bearing in mind is that when we have holoprosencephaly and facial defect, and this is an isolated finding, then it is not associated with chromosomal abnormalities. But if there is an extra facial defect, it is associated very likely with chromosomal abnormality. And the most common one found by the group of personiglides, more than 100,000 singleton pregnancy, is that holoprosencephaly is unassociated with about 78% of aneuploidies, and mainly in 62% is trisomy 13, and about 17% is trisomy 18 and triploidy. And when there are striking findings in the first semester that we can solve the trisomy 13 in relation to polydactyly, hyperechogenic kidneys, and increased heart rate. When we are performing an invasive testing and the target is not associated with chromosomal abnormalities, then we need to be cautious because we need to think of further genetic counseling. The holoprosencephaly is associated with some autosomal recessive and autosomal dominant inheritance syndromes, and those are in autosomal recessive it's Meckel-Gruber syndrome. And in some respect, there are mild forms that would be carried from the parents. For example, when there is a central incisor, maxillary incisor, this is also a hint for mild holoprosencephaly. And this, when the genetic part is very important because those forms are autosomal dominant and the parents need a further counseling. And in relation to how to summarize the holoprosencephaly, this heterogeneous group of malformation, a lobar form is and semi-lobar are little. With the lobar form, the life expectancy is with neurodevelopment delay and some visual problems. It needs to be the lower holoprosencephaly, something that we need to be very careful because this is a detection rate of 100% nearly in the first trimester. It means a good ultrasound and striking feature that must be remembered in our daily practice. And yeah, if the parents are committed to the pregnancy, then a common pregnancy care should be taken. I can stop at this point.
All right. Petya, you did in one way or another. Thank you very much, and then we will have your discussion at the end of this session. And then I'll make my presentation short as a last presentation because we are over time. And then this is about anatomical or functional level evaluation. Why is so important? Because every obstetrician should be taking care of this point because it makes sense. It makes sense. Here we go. I will share with you. Yes, can you see my presentation, Murat? Good. Excellent. Now, let's go here. This one. Okay. Why is so important? Because there are many clinical pictures of spina bifida, sequelae and comorbidities. We have to take care of it antenatally. But I have to say, after the many animal studies have been done before, many researchers has been done. But mom's trial, they made a great job, and then they said this is an open fetal surgery. and then fetal surgery is quite helpful for open spina bifida, reducing ventricular peritoneal shunt from 80% to 40%, and ambulation rate increased to 40%. After that, fetoscopic approach has come on the practice, still evaluation, but here you can see why I put these slides. This group change their exclusion criteria, as you can see on the right, from left side to right side. If you look at this one, after having a much more experience on this procedure, now there are few exclusion criteria for fetal spinal surgery. Therefore, we have to know level of the lesion, and then gestational age should be between 24 and 29 maximum, and then it should be a hindbrain herniation, no major abnormality, and normal karyotype. That is fine, but we have to remember that this graph showing very nicely then which, the level is controlling which function and motor function. And then we have to know that we have to remember why we are showing this one. Well before this, paper has been reported and telling us the prenatal in the time of intrauterine, period. Here you can see level of spinal defect, which is depicted. Is it, thoracal 4, but in the postnatal period is different. Look, this case, and if you go to this one, if you evaluate the motor function of the baby, it's quite different. Therefore, when you see the open spina bifida at the even higher level, we shouldn't be panic. Then we have to evaluate the motor function. This is another fact if we are talking about fetal evaluation and fetal spine surgery. Here you see this one, 2016 was published. They shared their cases. Here you see the prenatal anatomical level is L1, but after that post-surgical prenatal evaluation, you see the S1, L2, L4, L3, S1, and then going on this direction. Therefore, of course, the level of defect is quite important, but the evaluation of motor function of the baby is much more important than. Here we see, yes. Then we have to look at the legs, the knee function and ankle function, and the flexion and extension function, and then we can evaluate easily. If the position is not good, of course, you have to give a little bit more time, but it's not so difficult. Therefore, we have to evaluate not just the level of spine defect, also we have to evaluate motor function. Because significant differences between anatomical and neurological levels of the lesion, sometimes up to 6 levels above or below. Then, the fetal neurological evaluation is much more important than level of anatomical evaluation. In this study here, you see ultrasound predicted anatomical lesion level within one level of the postnatal findings, at least 50% of first cohort in the series, but in the second cohort of this group, the 89%. Therefore, then we have to look at, of course, ultrasound and MRI for the level of anatomical lesion, but bear in mind that the level of anatomical lesion could be quite different than motor evaluation of the baby. Here you see this example, and then of course, everybody knows how to count the vertebral body. Its ribs are our landmark, but bear in mind that in some cases, very rarely, that there could be the missing of 12 ribs, and just pay attention on that point. At the time of evaluation, that we are checking this one, the ribs, and the counting on which vertebral body we are evaluating. But this is important one side to make a diagnosis. But in terms of fetal spine surgery, the functional evaluation is much more important. We have to take care of it. In this example and this example, you can see, of course, we have to make it. I don't mean that this is not important, more important, but evaluation of motor function is quite important. Here you can see this one is a neurological level according to key muscle function. Here you see the segmental level L1. The psoas muscle is controlling hip flexion and hip adduction. But I have to draw your attention on that adduction. It is not possible to evaluate the hip adduction in utero by ultrasound and MRI, whatever, because this movement is not so difficult to make an evaluation. But it is better to look at hip flexion and extension, but usually knee extension, knee flexion, and then the ankle dorsal flexion and ankle plantar flexion easily can be evaluated, because thing is quite different. As you can see, ambulation and orthosis on the right side quite different than each level. Therefore, not just making a diagnosis at the level of ultrasound, at the level of defects, but we have to look at always motor function to look for functional evaluation. Therefore, if someone is talking about a fetal spinal surgery, then this should be taken into account. What kind of cases we do have, otherwise we will be surprised, and if fetal spinal surgery indication should be selected accordingly to motor function. This is now, thank you very much for your patience. I think we do have on time for discussion, and after that coffee. It is open now for discussion. I'm asking all attendees to put your question into Q&A box. Then we can follow your question, and then please welcome. Oh, okay, there are some, but before that, maybe the Oluş Api and Murat Yayla could help me to pick it up some important questions from Q&A and the chat box. But we will have another discussion about the ventriculomegaly tomorrow, which will be given by Vedran Stefanovic. But you said, Cecilia, you are doing, microarray in every case, even with isolated mild ventriculomegaly.
No, sorry. What we're not doing it in isolated mild. When they're non-progressive, isolated mild ventriculomegaly, we offer it to the patient if they want it, but we usually tell them we're probably not going to find anything. But right. We will insist on doing it if they're moderate or severe.
Yeah, good to know that. Very good. And then also you're giving us some more deep information about the MRI and comparison. What is the reason why the maximum 85% of MRI approval? Do we need an MRI approval, or what is the difference why 85% of concordance with the ultrasound and MRI?
Well, there is a high rate of confirmation of the neurosonography. The problem is that we sometimes miss pathology with neurosonography because the MRI targets white matter. So especially for proliferation, migration, differentiation anomalies, the MRI is going to be better for diagnosis. So there is a chance that there is extra pathology that we're missing. That is why we usually do it, and we try to do it at 32 weeks when the brain is more developed.
Yeah, but Cecilia, you are checking MRI around 22 weeks? Or
yes,
a little bit late, 30 weeks?
Well, the problem in Spain, well, not the problem, but the thing we have legal here is if you want to terminate the pregnancy, you can do it until 22 weeks. So we sometimes do it at 21, 22, because the parents want that information, although it may be incomplete. Once you go after 22 weeks, you have to go through an ethics panel. which may accept or not the termination. So if we are above 22 weeks, we wait until 32, but if we are below 22 weeks, we will do it at 21, 22, so they can have that information to decide if they want to terminate or not, and not risk going to the ethics panel who may approve or not the termination. So it's just for legal.
Yeah. Anyone can make a comment or raise a question from the panel also, not just attendee. Please raise hand. If I cannot see you. Does anybody want to add anything? Not. Cecilia, you've done a great job. Thank you very much. And I do appreciate it. And then now the Petya paper is open for discussion about holoprosencephaly. Does anybody want to make any remarks on or question? If not, until that time, Cecilia, Dr. Nejad is asking about, you do MRI on old mild ventriculomegaly at 32 weeks?
No, we don't. We don't, but it's a matter of resources. Actually, if you look at the latest papers, they're one by the ENSA group and one meta-analysis by Dimasio, they will tell you that mild, moderate, more moderate actually than mild, you have extra 5% of findings, and they're severe findings. So you have to take this into account and tell the patient, and then they must decide if they want it or not. It's very little chance that you will find something, but if you find something, it will be something probably severe.
I mean, if the family would like to continue the pregnancy, you know, it is better to do MRI if you do later on.
Exactly, exactly. So we will only advise it if this is going to change their decision on continuing or not the pregnancy.
Excellent. There is another question. Anna is asking, how is the angle in case of myelomeningocele and myelocele? Please, better differentiation help. Yeah, in myelocele, there is a skin covering of the lesion. Therefore, it should be expected to see a wider angle. And in myelomeningocele, it will be blowing up. Therefore, angle will be narrow. That is the hint, but always we have to look for, of course, skin tissue and the subcutaneous fat tissue over the lesion. Right, Yash is asking to Petya, how to precisely differentiate between lobar holoprosencephaly and the isolated agenesis of septum pellucidum? Petya.
This was something of maybe one of the, can you hear me?
Yes, we do.
Okay, when we are speaking about lobar holoprosencephaly and isolated absence of cavum septum pellucidum, the most prominent view that you need to take in ultrasound is the coronal view. And then you can look at how the anterior ventricles, they have communicated in their posterior regions, and that communication represent actually that there is not complete visualization of the interhemispheric fissure, and this is how you can distinguish between those two abnormalities.
All right.
Essentially, in the lobar holoprosencephaly, there is a communication of the anterior horns in their posterior regions, which is the striking finding.